فيها دكتور احمد راضي، استاذ دكتور احمد راضي، استاذ كليه طب جامعه اسكندريه قسم الطب النفسي. الموضوع بصراحه شيق وكان نفسنا نسمع عنه كتير، ودكتور احمد حابب ان هو يديه لنا بصوره مختلفه شويه. Psychiatric manifestations of neurological disorders. هو وعدنا ان هو يقولها بطريقه مختلفه عن ان احنا نقول الديسوردرز وكل حاجه تحصل فيها، اظن احنا هنعملها بالعكس يا دكتور احمد. شرفنا دكتور احمد ان شاء الله، اتفضل يا دكتور احمد.
طبعا بشكر كل الحاضرين، وكمان عارف مجموعه كبيره منكم، والواحد بيبقى مبسوط لما بيقابل الناس في المعموره. Psychiatric manifestation of neurologic diseases ممكن يبان موضوع سخيف للبعض، بمعنى انك انت هتيجي تقول والله ايه الكوموربيديتيز بتاعت الابيليبسي، ايه السايكاتريك مانيفستيشنز في واحد عنده سي في اس، وتقعد تقول والله ده الكوموربيديتي بتاعت الديبريشن عالي والاو سي دي عالي وبتاع، وفي الاخر بتلاقي كل عمليه من السايكاتريك مانيفستيشنز موجوده ان هاير برسنتج في العيانين اللي عندهم نيورولوجيك ديفيسيت. انا رايي ان دي ما هياش طريقه عمليا نعرض بيها الموضوع، واحنا اللينك بين النيورولوجي والسايكاتري كبير في المانيفستيشنز، بس احنا عاوزين ناخد كونسبت عام كبير وننزل نطبقه على كل الديزيزز علشان نشوف حتى لو انت ما انتش عارف تقدر يو كان اكسبكت ايه اللي ممكن تلاقيه كسايكاتريك مانيفستيشن ان اني نيورولوجيكال ديسوردر. يمكن احنا فاميليار كتير بالناس اللي بتبريزنت بالنيورولوجيك ديسوردرز ولكنهم كونفرجن ديسوردر او هيستيريكال، انما اللي هنعمل عليهم تركيز الناس الحقيقه اللي بتبريزنت بالعكس، يعني بيبريزنت by psychiatric manifestations but in fact they have a neurological disorder. All medical disciplines بتشوف particular interest بالholistic health model, biopsychosocial model. Biopsychosocial model يعني is not a term to يعني just to be written in literature, but it should be translated into clinical application. Psychological manifestations and physical dimensions or neurological manifestations can be both manifestations of a single organ disorder. The brain is responsible for both, and it can be automatically expected that any disorder of the brain may manifest as psychological or as physical or as both. Diseases do not come to you as a physician. Who comes to you is the patient himself. And patients are frequently explaining their symptoms in terms of psychological impact and not in terms of physical deficits. When you are evaluating a patient with neurological disorder, it's common that you search for sensory deficit, motor deficit, and cerebellar functions. But it's very rare to find in the standardized way to evaluate neurological disorder, to evaluate the cognitive impairment and the behavioral disorders or the psychiatric or the psychological manifestations of the disorder. And this is the general concept. The most important key that I want you to get from this lecture. When assessing the impact of the neurological disorders in terms of the psychological manifestations, we have to think about 4 dimensions. We have the temporality. Any disorders that goes fast with acute presentation can give delirium, and delirium can manifest itself by psychiatric manifestations. Most of you when evaluating delirium, usually physicians ask the patient if they are aware of their place, person, or people around. In other terms, they are evaluating disorientation. Do you know that the scientific literature is showing evidence that disorientation is the least cognitive impairment that can be found in delirium? Is the least. The most common is inattention that may appear as apathy. Patients are not showing emotional reaction. and can be easily missed as a patient who is distressed, patient who is irritable, but in fact it's the starting manifestation of a delirium. Delirium has some criteria like fluctuating sensorium or cloudiness of consciousness, particularly in the evening hours, what we call the sunset phenomenon. However, any disorder with acute manifestations can give rise to delirium, while all chronic neurologic disorders can lead to chronic impairment of cognitive functions and loss of cognitive abilities over time, leading to some sort of dementia, a full-blown picture, or partial. All chronic illnesses in neurology can do that. So the first dimension is the temporality. The second dimension is the localization. As we said that the brain is a single organ. It's responsible for psychological manifestations and responsible for another neurologic manifestations. So if I have a lesion in one area, I can expect if it can present with psychological or neurological. And I will give you very simple examples. If you have a lesion in the prefrontal cortex in the supraorbital area, the prefrontal area, what we call the ventral aspect of the prefrontal cortex, you may get a patient with manic disorder as a presentation. And there is a patient who has been transferred here, and I think some of you were taking care of him in a group of psychotherapy. And in fact, he has dysplasia, frontal dysplasia, and he is still, I'm seeing that patient on a regular basis. And he improved a lot after the surgery has been practiced. But he was presenting as mania, hypertalkativeness, lack of sleep, and he turned very aggressive all of a sudden when he burned the house of his uncle and so on. And this is when he has been transferred to Mamoura Hospital. And I think that the prefrontal cortex is responsible for mania. Lesions in the prefrontal cortex, also in the supraorbital part, can lead to obsessive symptoms. Some lesions in the dorsolateral aspect of the prefrontal cortex can lead to disinhibition. So patients are disinhibited. Like hypersexuality, for instance, in older age. That's why in some patients you may find not a classical full-blown picture of mania. You may have some symptoms. And at that time, you have to recheck whether we have to go for radiologic assessment if there is a structural brain lesion or not. Cerebellar lesions. At one time, one of the theories of schizophrenia was considering what they called cognitive dysmetria. There is a movement dysmetria. I cannot evaluate this space, so whenever I'm trying to reach that paper, I may overshoot, or my hand may not reach as a proper distance to reach the paper. This is what we call dysmetria. All of us, when evaluating the function of the cerebellum, we are evaluating motor dysmetria. But do you know that cerebellum is causing cognitive dysmetria as well, which is causing a lot of dysexecutive functions that may be part of the schizophrenia. All lesions that may lead to cerebellar dysfunction may lead to some sort of cognitive dysmetria that appear in dysexecutive functions that may be confusing with mania and sometimes with obsessive compulsive disorders as a compulsory act and compulsory behavior. We have the neurotransmitters. What kind of neurotransmitters that are implicated, and we can predict automatically what kind of psychological manifestations we may get. Parkinson's disease is a very good example of that. I have dopamine that lacks. It may lead to bradykinesia, shaky hands, and other manifestations of Parkinson's disease. But lacking dopamine can explain the high frequency of depression, the apathy, lack of emotional reaction, the disinhibited behavior that may occur from time to time, And many Parkinson's disease, in fact, are presenting with psychological and not presenting by motor symptoms. So we have a prodrome that can go for several months, up to 1 year, with psychological manifestations, particularly hypersexuality. Many of patients with Parkinson's disease are hypersexual, trying to touch nurses and trying to sometimes make some sort of harassment to women around, while in fact it's not part of their character. This is far before the shaky hands and the rigidity appears. The same thing for dementia. Dementia is well known for a lack of the acetylcholine from nucleus basalis of Minard. And when acetylcholine is lacking, it leads to apathy. And sometimes patients with dementia may present with apathy long before cognitive impairment appears. And I think most of you have came across patients who you were considering depression in old age, and then the family started to describe cognitive impairment, and then all of a sudden they went into a classical dementia. Even the term pseudo-dementia, sometimes this term is used for depression in elderly that may manifest with cognitive impairment. Do you know that pseudo-dementia, in fact, increases the risk of being demented by 3-folds? And most of patients, in fact, if not properly treated, go from pseudo-dementia to true dementia, and you will not find a clear delineation. So the prospective studies don't show that clear delineation between the psychological manifestation in old age and a true loss of functions. As part of it is the emotional reactivity that may be lost due to acetylcholine deficit that can explain the cognitive impairment and can explain the loss of emotional reactivity and depression on the other side. And the fourth dimension is the personal differences, like the educational level, the smoking habits, the age, the socioeconomic status, the gender, whether male or females, and that stuff. So whenever you are coming across a neurological disorder, try to find what kind of psychological manifestations you may expect in terms of temporality, location of the lesion, what neurotransmitter is impaired, and if there is a special gender or a special category that are at higher risk. I will take some disorders, but as a group, but not individual one. And I want you to apply those concepts to each group. Let's take a look on hereditary neurological illness. And they are a lot. But what's characteristic is that in all hereditary neurological illness, there are psychological manifestations. And most of them are in fact presenting by psychological and not neurological for some time. Let's take Huntington's chorea. Its name indicates choreic movement, the fork, the hypotonia when you are extending your arm, and the choreic movement. عارفين choreic movement? Mild flexion and supination, then extension and pronation. So flexion, supination, extension, pronation. This is the choreic movement. But you know that Huntington's chorea is very highly comorbid with depression. But in fact, depression precedes the manifestation of neurological symptoms in many cases. It's autosomal dominant. So whenever you have a family history of Huntington's chorea and you find that one of them is manifesting with depression, you may try to explain that as a coherent logic way that maybe he is depressed, he is afraid that he may get the disease, but in fact he is starting the process to get Huntington's chorea as a manifestations later on. Wilson disease, it's a problem of copper. I think you are familiar with the ring, the copper ring that you may find in the iris. It affects many organs, And Wilson disease is very famous that you can put in all differential diagnosis because it can manifest itself by any neurological sign. But did you know that many Wilson disease do present with suicidal thoughts rather than neurological disorders? And obsessive symptoms. So usually they manifest by obsessive symptoms and suicidal thoughts for some time before they develop a neurological deficit or involuntary movement. Acute intermittent porphyria, famous by the severe colics in the abdomen. But you know that in many cases, it presents with psychological manifestations. Anxiety, agitation, hallucination. And very frequently, they are confused as being hysterical for many years before a proper diagnosis is being made. Acanthocytosis also can be put in many differential diagnoses because of the hetero or the polymorphism with which it may manifest itself. It's very famous for the acanthocytosis, the spikes. You will find that the RBCs are having spikes. And I will give you one example of a case. This is a 50-year-old unemployed man was referred to the emergency department psychiatric service because of impulsive and disinhibited behavior, going naked into his back garden and talking loudly to himself in public. He was sleeping poorly. His wife reported that he has been hoarding junk in his house. All those are psychotic symptoms for many years. He had been sacked from his work as a chef about 10 years before because of disorganization. He was an only child and there was no relevant family history. He had been fidgety since childhood. Examination revealed lack of insight and inappropriately jocular manner, chorea, borderline wasting of the lower legs, and areflexia. His creatinine kinase was very high. So this is a routine examination. The creatinine kinase, they ask the ALT, because whenever there is something wrong with the muscles, you have aldolase that goes high, creatinine kinase, and the liver enzymes. All those manifestations and the age are suggesting psychotic symptoms in an older age. But in fact, he has simple acanthocytosis. And his behavior progressed eventually, and he has been put to compulsory detection under Mental Health Act, which is a true case. Even what we may expect as hereditary illness that are very restricted to a system, like spastic paraparesis, hereditary spastic paraparesis. This is a patient who is manifesting by bilateral pyramidal manifestations in lower limbs and scissoring gait and bilateral hemicircumduction gait in both legs. But do you know that hereditary spastic paraparesis is in fact presenting with psychological manifestations? Psychological manifestations and not neurological manifestations some months or some years before manifestations, as an anxiety, depression, or sometimes obsessive symptoms. The same for spinocerebellar atrophy and all kind of ataxias. Spinocerebellar atrophy, the most famous among them is the Friedreich ataxia. And all of them present with psychological manifestations sometime before presenting the neurological manifestations. And this is a typical case of spinocerebellar ataxia, Friedreich. But it's not presenting with ataxia, presenting in fact with psychological symptoms. So a 46 years old man was referred with a 5-year history of personality changes, labile mood, expressive outburst, inflexibility about routines. He complained of forgetfulness and difficulty in doing more than one thing at a time. His speech had become mildly slurred, his gait slightly unsteady, and his dexterity has declined. Although he scored 30 over 30 on many mental state, comprehensive neuropsychological testing showed that he has some sort of dysexecutive functions or executive functions that are impaired. And this is a patient with spinocerebellar ataxia presenting in older age. Metachromatic leukodystrophy. Pervasive developmental disorders in neurology. I know that you are not practicing neurology, but should be familiar with. We have two kinds of major categories. We have polyodystrophy and leukodystrophies, whether you are affecting the gray matter or you are affecting the white matter. They are normal, growing children, and all of a sudden they have a decline, and this decline is pervasive and it's continuous. We have three major subtypes of the leukodystrophies, and they are presenting by simply the affection of the white matter. So they are the long tract, bilateral pyramidal, cerebellar dysfunction, and affection of the optic nerve with progressive loss of vision. These are the three triads. One of the commonest among them is the metachromatic leukodystrophy. Always remember that name, because metachromatic leukodystrophy presents itself with a typical schizophrenia for many years before developing bilateral pyramidal. It's a very famous in neurology that this disorder does not present with bilateral pyramidal. It presents with schizophrenia, typical classical schizophrenia, with positive and negative symptoms of schizophrenia, and receive treatment for schizophrenia for many years, and then start to develop bilateral pyramidal that can be missed for extrapyramidal rigidity. It's a metachromatic, and the radiology is showing the dissolution of the white matter around, and that's why radiological examination is very important as the workout for patients who had no previous psychiatric history, and particularly if there is poor response to treatment. So always remember, neurohereditary disorders do present with psychological manifestations in most of cases. So it's not an exception. In fact, it's the rule. And we have the neurodegenerative disorders. And all neurodegenerative disorders are chronic illnesses. So you can expect, in terms of the temporality axis, that they can present with cognitive decline that goes progressively and increases with time, leading to psychological manifestations that are relevant to the cognitive impairment, particularly the production of emotion. As far as I cannot interpret what you are saying as being something nice, I cannot give a reaction and smile. And this is what you may find in all neurodegenerative disorders, where the psychological manifestations are omnipresent. A 63-year-old man was referred because of his wife's concern about a change in his personality, previously affectionate and meticulous. He had become increasingly detached and self-obsessed. On a recent occasion, he had walked down the counter of a local cafe, picking up, sniffing, and replacing each cake in turn. His speech was slightly slurred, with mild words finding difficulty. He had bilateral palmomental reflexes. Do you know the palmomental reflex? When you make a stimulation of the palm, the patient will do, it's called like that. You do like that. Usually it's in the baby they are found, and then they are inhibited with time when your cortex is intact. But when the cortex become more atrophic, the primitive reflexes appear back again because they are not inhibited anymore, like the starter reflex and like that one, palmomental. And he scored 30 over 30. And I'm insisting 30 over 30 because this patient cannot be easily diagnosed as being demented. He's scoring 30 over 30. Even the screening doesn't get it. But this patient is a classical case. ده ايه اللي طلع؟ But this is a classical case of frontotemporal dementia. When you have a frontotemporal dementia, particularly affecting your left side of the brain, causing atrophy, which is the frontal atrophy dementia, a specific type of the frontotemporal, it presents with some sort of subtle dysphasias. Subtle dysphasias. There are dysphasias, which is a larger term than simple aphasia. Aphasia is a very, you never find a classical aphasia in the proper term. We have dysphasias and paraphasias, many paraphasias. Are you familiar with paraphasias? We have one of them is the phonetic paraphasias, which is I cannot find the proper pronunciation, the musicality of the word. For instance, I say, عاوز أشرب مية. I try to find the proper pronunciation. This is a very early sign that I have a problem in my language before I cannot talk. Whenever I cannot produce language anymore, I'm already very late. And at the same time, I may have semantic paraphasia. I mean, giving one word instead of another. But both of them can be categorized with a semantic logic way. يعني أقول اديني القلم، أقول له قصدك المسطرة؟ أيوه هي المسطرة دي. But both of them can be used in as disk objects, for instance. أو أقول له اديني الموزة دي، موز فين؟ قصدي الجوافة دي. Replacing one word with another can be categorized. These are the subtle signs that you have to pick them. These are some of the famous degenerative disorders we have. You have to put in mind that all of them are in fact not presenting by neurological signs. They are presented by psychological signs. Parkinson's disease is one of them. Sleep behavior disorder. REM sleep behavior disorder is the common presentation of Parkinson's disease many years before Parkinson's disease manifests. Restless leg syndrome is one of them. Do you know that the supranuclear palsy, احنا عندنا باركنسون وعندنا باركنسون بلس، اعرفهم كده كلينيكالي. باركنسون يعني باركنسون ده كلاسيكال اللي هو فيه شيكي هاندز وكل حاجه، واديله سينمات يخف الايديوباثيك. انما في باركنسون كتير الاقيه مخشب جامد بس الشيكي هاند ار مينيمال، يعني ما فيش رعشه ايد، مخشب بس، وبلاقي الريسبونس تو سينمات از فيري بور. بسميهم باركنسون بلس. في الغالب ده باركنسون مع حاجه ثانيه، يعني multiple system atrophy. Supranuclear palsy is one of the famous. This is the second most type of Parkinson plus syndrome. بيتعرف نيورولوجيكال ازاي؟ عنده restricted upward gaze. العين لما تيجي ترفع restricted، ما اعرفش اجيب نهايه الرفعه. بس وله اسم طويل بيسموه ريتشاردسون ستيل اولزافسكي syndrome. It's famous. It's the commonest type of Parkinson plus syndrome. But do you know that the common presentation of supranuclear palsy is delusional jealousy? What we may diagnose as delusional disorder, jealousy subtype, for many years before it presents with restriction, rigidity, and restricted movement. So whenever a patient comes with delusional disorder, with jealousy subtype, and you give a conventional antipsychotic, then the patient starts to develop extrapyramidal side effect that may be confusing with the Parkinsonian features, and you can easily miss a Parkinson plus syndrome because there are many other abnormalities that you have to take care of. The supranuclear palsy has no treatment on a practical basis, but you should take care that these patients have severe orthostatic hypotension that may worsen with your antipsychotic. And so a lot of fall down, a lot of fractures and side effects related to the frequent falling. Lewy body dementia usually present with visual hallucinations. vivid visual hallucinations many years before developing the Parkinsonian features and the dementia, because both of them occur at Lewy body disease at the end. Even in dementia, as the commonest degenerative disorder in neurology, the commonest presentation is apathy. The commonest presentation is apathy and not cognitive decline. Famous neurological sign called alien hand syndrome. Alien hand. My hand is moving as it's not mine. It's moving spontaneously, I cannot stop it. Intermittent. It's a very common manifestation to a disorder in the cingulate gyrus. And cingulate gyrus is very sensitive to hypoxemia. So in all operations where there is a sudden change in the circulation dynamics, you may find the spots of lesions related to ischemic lesions in the cingulate gyrus. It presents with alien hand that can be easily diagnosed as nihilistic delusions. Neuro and all CVS and vascular disorder, you can imagine where is the lesion and just remember what psychological function that can be carried out by that lesion. Because in fact, the high morbidity of depression relevant to CVS is not simply related to the fact that they are reactive to a neurological lesion. And this is very famous for the left middle cerebral artery occlusions, which is the commonest type of occlusion that occur in AF, atrial fibrillation. Because in fact, the relation is not simply they are depressed because they have language problem. In fact, neurotransmitters decrease a lot, norepinephrine and serotonin. So it's a structural lesion that lead them to be depressed and lead them to have dysphagia. It's not a simple reaction. The neuroinflammatory disorders. There are many neuroinflammatory disorders. We have multiple sclerosis as one of them. I know that part of the very common manifestations of multiple sclerosis is intermittent psychological phenomena that may indicate hypomania. In the neurological text, you will read that these are intermittent phenomena and have to be treated with anti-epileptics, like Tegretol. But in fact, you are stabilizing the mood. The emotional lability is very famous as a sign, neurological sign in MS. And you give an antidepressant, particularly tricyclic antidepressant. So it's part. This is the most famous neuroinflammatory disorder. But always remember that neuroinflammatory disorders always represent themselves by psychological manifestations as well. Remember systemic lupus erythematosus that can present with psychiatric manifestations, with depression. And I say, well, it's a depression relevant to the systemic lupus or part of the encephalopathy. And what applies to systemic lupus applies to all autoimmune neuroinflammatory disorders. I choose this example, the spongiform encephalopathy, because I have just seen one patient a couple of weeks ago at the ICU unit, and I have been invited by his sister, who is insisting that his wife is the reason for that, because of the psychiatric manifestations with which it usually presents. The commonest type of spongiform, you know that it's a slow kind of a disease caused by prion. And these are between virus and bacteria because it's a protein material, but it can be carried through bovine materials, particularly meat. The commonest type of spongiform encephalopathy is fatal insomnia syndrome. It presents with severe anxiety, sometimes panic attacks. Then the patient doesn't sleep at all, and he keeps for that for some days or for some weeks. And he goes to psychiatrist because of severe anxiety and severe insomnia. It's called fatal insomnia. And that's why his sister is trying to say, no, there was something and he got angry because there's something going wrong with his wife. This is the way they are trying to explain. She is not faulty. This is what is apparent to her. And that this is what happened. He went very anxious, talking to everyone that he's anxious and he cannot sleep. Then total insomnia. Then cognitive decline, then coma and myoclonic shocks. Though there is no clear treatment, but there are many trials on certain substances that may hold the progress. So it's practically speaking, you can hold the progress. Fatal insomnia syndrome. It's called like that. Severe insomnia. This is the presentation. For many weeks, many months. The brain neoplasms. Of course, a neoplasm, whenever it's present in a certain loop, it will produce psychological and neurological manifestation relevant to the loop. But what interests me more is the paraneoplastic phenomenon. You have paraneoplastic neuropathy, paraneoplastic myopathy. One of the famous paraneoplastic syndrome is the paraneoplastic limbic encephalitis. And you will find here the limbic system that goes hyper intense in T2 weighted images on the MRI. Do you know how it does present? It's simply behavioral changes. And it can be easily mistaken that this patient may have limbic encephalitis or may present with herpetic encephalitis that takes both temporal loops. It's a very similar one. But when you do the PCR for herpes simplex virus type 1, you will find it negative. So the common presentation in this patient with paraneoplastic limbic encephalitis is behavioral changes, disinhibition, and typical manifestations of mania and hypomania relevant to the affection of bilateral temporal pole. But in fact, they have to direct your attention that there is a neoplasm elsewhere in the body. Particularly, by the way, prostate cancer. So when you find a patient with prostate cancer who is developing manic episode, you may suggest that this patient may have paraneoplastic limbic syndrome. And always remember that sometimes paralimbic or paraneoplastic manifestations can be explained in part by autoimmune antibodies that go wrong with some antibodies that are attacking certain areas. And there are some data in literature that some paraneoplastic syndromes may get benefit of plasmapheresis. So whether it can be preventable or not, there is a question mark. But at least you have to know that this is a common presentation, particularly in certain neoplasm like chest carcinoma and prostatic neoplasm. Traumatic brain injury. I will not talk about a brain contusion that can manifest itself neurologically or psychologically, but I'm more interested in chronic subdural hematoma, a very common finding in our daily practice. And often patients do not give any history of brain trauma, no head trauma. It's a common side effect for those receiving anticoagulants and very common in old age because simply you have the subdural part where there are the bridging veins and the wall is very thin and weak with old age. And whenever they are coughing or having constipation or having a common cold, they can easily rupture. And when it develops slowly, and you can easily differentiate subdural from acute extradural of the curvature of the inside. The subdural is taking the curvature of the brain, while the extradural is concave, convex. It's the opposite. Here it takes the curvature. So this is chronic subdural hematoma. The manifestation of chronic subdural hematoma is in fact one of the causes of reversible dementia syndromes. So it usually presents with psychological manifestations, particularly apathy, depression, for long, long months and years, even they can be easily missed as far as you don't get it. And whenever you correct it, manifestations are entirely reversible. At least for the psychological manifestations. For the cognitive, some data in the literature suggests that it's pseudo-irreversible, because whenever you evacuate the subdural hematoma, the progress stops, but the deficit remains. Nutritional deficiencies can be easily missed for both. You know that vitamin D, for instance, is frequently presenting with general fatigue and depressed mood, and not neurological manifestations. Wernicke-Korsakoff, that occurs with alcohol. It manifests itself by ataxia and ophthalmoplegia, confusion and anxiety, irritability, and sometimes aggressiveness. But you know that it can be corrected easily by vitamin B6. It's thiamine that you have to give. Vitamin B12 is very famous. That can cause anemia and cause that. But it's one of the common causes of nutritional depression. And this applies to all vitamins that are highly nutritional value to the brain. Lastly, we are going to tackle briefly the neuropsychiatric manifestations of sleep disorders, because they can manifest both. And all of us are familiar with narcolepsy, which is excessive daily sleepiness. And its clinical tableau or clinical manifestation, you'll find cataplexy. So whenever there is a strong emotional reaction, he simply loses the tone of truncal muscles and he falls down. Do you know what happens, in fact? It's a REM pattern of the EEG that comes all of a sudden. When you have a REM stage during sleeping, you have non-REM and REM. And during the non-REM, you have stage 1, 2, 3, 4, and then REM. And this is one cycle. And usually you have 4 to 6 cycles. And the first REM is after 1 to 1.5 hours, what we call the REM latency. This is the normal sleep structure in brief. And during the REM, you lose the tone of your truncal muscles. If you don't lose them, you will act your dreams. So what happens is that the same EEG of a REM sleep pattern come all of a sudden in awake patients. So he falls down immediately. Hallucinations. Hallucination, it's part of the clinical traditional presentation, particularly when waking up or when getting sleep, what called hypnopumping and hypnagogic. But they are very vivid hallucinations. And sleep paralysis. When waking up, he feels that his movements are very heavy to move for a while. We have REM sleep behavioral disorders that may be easily diagnosed as hysteria, or sometimes epileptic seizures, while in fact it's the psychological manifestation of a sleep disorder that has nothing to do with epilepsy. And I think that all of you can observe that the diagnosis of having abnormal electric activity of the brain is very abused in the market, and they are given to many children who are in fact not epileptic at all. And one of them is the sleep behavior disorder, and you have many parasomnias, sleep talking, sleep mobility or the somnambulism, sleep paroxysm. All of these are non-REM disorders and night terrors. In psychiatry, we consider them as neurotic traits because they predispose, in fact, to many psychiatric disorders. So many sleep disorders do present by both psychological and psychiatric, but more with psychological symptoms that may be misdiagnosed or overlooked. Do you know that many of the parasomnias are very common in neurodegenerative disorders? Parkinson has many parasomnias that develop late in age. Multi-system atrophy is very famous of that. Multiple system atrophy is one of the Parkinson plus syndrome, but it manifests itself by many parasomnias many years before it starts to have the full-blown picture of the illness. The epilepsy is an intermittent hyperactivity or electric discharge from the one area of the cortex, what we call the epileptic focus. And many symptoms have been related to the epilepsy, whether it's related directly to the epileptic seizure that may manifest itself by psychomotor manifestations, with psychomotor agitation rather than motoric convulsions, and can be easily confused with intermittent impulsive disorder, for instance. Or it may be related to the post-ictal changes that may imitate psychiatric manifestations. And I will give you a very interesting example that I have been read recently in the literature, that they took patients who have hypomania with religious conversion, who changed their religion during a hypomanic episode, and they proved that more than 60% were in fact having post-ictal seizures. It's an interesting finding. I don't know what's the exact relation between that, but at least it's a finding in the literature. So what I want you to take as two messages, always to remember that when evaluating a patient for neurological assessment, don't miss the cognitive assessment, behavioral assessment, and psychological manifestations. If there is something psychologically that's not part of his normal habits or his normal behavior. And always try to make or to analyze the interference, or not the interference, I say the interface between neurologic and psychological manifestations, taking in consideration 4 axes. The temporality, is it acute or chronic illness? So will it has a pervasive cognitive impairment, or will it manifest with delirium? And the localization of the illness, what kind of neurotransmitters that are involved, and how they may manifest as psychological, and how they can manifest as neurological, and lastly, whether it affects a particular age group. For instance, a neurological disorder that affects childhood, you may expect that depression in childhood do not manifest themselves like adult, they manifest themselves as externalization. Start to be aggressive, steal, lie, what we call externalization of the symptoms. So that depends on how they are going to manifest those psychological symptoms. And thank you very much.